Neurocysticercosis. Cysticercosis is a disease caused by the infection with the larval stage of the intestinal cystode called Taenia solium. It occurs when human or porcine become intermediate host, and the parasite has marked tendency to infect muscle and the central nervous system, where it produces a pleomorphic clinical disorders called neurocysticercosis. In many developing countries, it is the most common parasitic disease on the central nervous system and accounts for almost 10% of all acute neurological disease. There are wide variations of clinical manifestations of neurocysticercosis, but epilepsy remains the most common manifestation, occurring for almost 2/3 of affected patients. Seizures in neurocysticercosis may be generalized or simple partial with focal motor signs. And a study with Medina found 72% of patients who had partial seizures, while Del Brito find generalized convulsive seizures in 38% of cases. What are the main etiologies of epilepsy on HIV-infected patients? First of all is cerebral toxoplasmosis. That accounts for almost 30% in our personal series, followed by meningococcal cryptococcosis, 10 to 15% in Cameroon, 16% in a study in Burkina Faso, and 8% in South Africa. We have central nervous system tuberculosis. That is 64% in South Africa, where we know the prevalence of TB is very high, but only 16% in Cameroon. And we have other etiologies that you know, CNS lymphoma, HIV encephalopathy, stroke, and we know that almost 28%, for 28% of patients, we don't really know the etiology of seizure. The recommendations for the treatment of seizure on patients with HIV, as first-line drugs, you have to use valproate, gabapentin, oxcarbazepine, pregabalin, or levetiracetam. And as second-line drugs, it's recommended to use lamotrigine, topiramate, tiagabine, and zonisamide. You will see that the only drug that is available in the African continent is valproate. We have to avoid phenobarbital, phenytoin, or carbamazepine, and benzodiazepine should be used mainly for emergency or short-time duration. CNS tuberculosis have three main clinical presentations. First of all, tuberculous meningitis, meningoencephalitis, and cerebral abscess. And seizures are frequently associated to meningeal signs and signs of raised intracranial pressure. CNS tuberculosis causes epilepsy as a late sequela for 8 to 14% of patients and is frequently associated with hemiplegia. And we know that epilepsy is a common manifestation of intracranial tuberculomas that present as slow-growing, space-occupying lesions. The management of CNS tuberculosis starts with image, CT scan, that shows a ring-like lesions with contrast enhancement. And one thing you should know is that sometimes tuberculoma can be discovered accidentally in asymptomatic individuals and in children with focal or generalized seizures. The management of tuberculosis is with these 4 drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol. And the duration of the treatment varied from 8 to 9 months. And the treatment management of seizures is based only on the 4 main anti-epileptic drugs that we know. Pyogenic meningitis is also common in the tropics. And epidemics of meningococcal meningitis occur from time to time in sub-Saharan Africa. And large-scale epidemics are confined to semi-arid area of sub-Saharan Africa from Senegal in the west to Ethiopia in the east. In a study of 185 children who were followed up for bacterial meningitis, 13 developed one or more febrile seizures after the initial hospitalization. And these findings then confirm that intracranial infections are important risk factors for epilepsy. The management of seizures due to pyogenic meningitis is mainly on antibiotics for 14 to 21 days. First of all, is third generation cephalosporin associated with amino acids, or ampicillin associated with amino acid or thiamphenicol, and the seizures are managed with carbamazepine, phenytoin, phenobarbital, or valproate. To conclude, I would say that intracranial infections are etiological factors for epilepsy, and many are preventable. Epilepsy and other long-term sequelae of intracranial infections can be minimized by early detection and prompt and adequate treatment, as we saw. But the main problem in Africa is, first of all, the availability of diagnostic tools and human resources, is the limited economic conditions and the lack of access to anti-epileptic drugs. Thanks for your kind attention.